One's easy. First and last name, spelling.
Rolando Saenz, it's Rolando. Saenz is Saenz.
And then your official title.
I'm a board certified general and colorectal surgeon. I'm board certified in both.
Good stuff. Obviously, prior to this interview, very passionate about your work. Talk to me about colon cancer, what it is, and what you've seen as of late here in San Antonio.
So colorectal cancer, and the two are grouped together, although they are treated a little bit differently. First of all, anatomically, we're dealing with the colon and the rectum. That's the last part of the gastrointestinal tract, or the GI tract, where you digest your food. Specifically, it starts on the right lower side of the abdomen, and the colon goes up across under the stomach and under the liver, down the left side, kind of makes some turns, and as it goes down lower, it turns into the rectum. This is where you absorb a lot of your water. You do absorb some nutrients, but it also stores stool before it gets evacuated. And with regards to colorectal cancer, what we're dealing with is an abnormal growth. The vast majority of colon cancers are adenocarcinomas, and that's just kind of the cell type. And these are these abnormal growths, which either because of genetic reasons, probably exacerbated by dietary reasons, these abnormal cells grow. They continue to grow at a faster rate than the surrounding cells, and they grow in an abnormal fashion such that they essentially outgrow their surrounding cells and essentially turn into a cancer. I mean, that's kind of basically what a cancer is. As it grows, it essentially becomes almost parasitic off the body, where its goal is to stay alive. So number one, it grows. It can grow to the point where it can block the colon. It can cause significant amount of bleeding. It can spread to other parts of the body, usually lung, liver, brains, adrenal gland. And eventually, potentially lead to the demise of the patient. With regards to the things that we've seen, I mean, colorectal cancer still remains the second most common cause of cancer deaths in the United States. There's, with this in mind, we've done quite a bit with regards to diagnosis. We've definitely done a fair amount with regards to treatment, but it still remains a huge problem. One of the big concerns as of late, and the American College of Gastroenterologists came out with some specific recommendations about 3 years ago in response to seeing more and more colorectal cancer in younger age patients. That group, the 20 to 49 age group, we've definitely seen significant amounts. It's essentially almost doubled with regards to colon cancer and quadrupled with regards to rectal cancer. And so with this in mind, a lot of attention was drawn to this age group. I mean, yes, we talked about celebrities being, in the news with regards to developing colorectal cancer at a young age. I think that really brought things to light. And with that, the newer recommendation is starting our screening examinations at the age of 45. It used to be age 50. So now at the age of 45, and proceeding with, depending on what's found, with follow-up screening examinations. I mean, with these recommendations, it was also a recommendation that starting at the age of 75, maybe we shouldn't be screening these individuals. Really, the way that the guidelines were written is it's kind of up to the discretion of the particular physician. But in all frankness, I mean, I think we shouldn't, sell our elders short. I mean, a lot of our elders are living longer healthy lives, and these folks definitely need to be screened. So in all frankness, I have a patient right now that I just operated on 2 days ago in their 80s, and she's in great shape. But unfortunately, it's my understanding that at some point in time she felt, or her physician felt, that she didn't need to be screened. And to me, if you're in your 80s, definitely in your 70s, and if you're up and about and can handle your business and good mentation, et cetera, great quality of life, that's like I said, we shouldn't sell our elders short. They definitely need to be screened as well.
You said 20 to 49 was the age range that had seen an increase.
Correct. While over the age of 50, we've actually seen a bit of a decline of incidence of colorectal cancer. I mean, the presence of polyps in, colorectal cancer begins as these growths that I mentioned, these polyps. I mean, they still exist. But because I think, especially the American Cancer Society has done amazing things to really make and raise the awareness of colorectal cancer and the need for screens, that 50 and older age group, I think, is done, has shown a tremendous amount of diligence. And so we have seen a decline. But we are seeing, I mean, we always have seen colorectal cancer in younger age groups, but the incidence has definitely gone up.
So that being the case, as young as 20, why is the recommended age of screenings 45?
The short answer is it is now. I feel that the age is going to, the recommended age of colonoscopy is going to continue to go down to a younger age group, number one. Number two, I mean, that's just for routine screening. That you definitely need to come in and get an exam. Definitely, that doesn't take away the fact that if it's a younger age person, say 30, that's experiencing any kind of rectal bleeding, consistent change in bowel habit, not just episodic, but consistent change in bowel habit, certainly just query abdominal pain, weight loss definitely, but usually when we start to see things like weight loss, I mean, the cat's really out of the bag with regards to this being extensive cancer. So any change in GI habit that I've just mentioned, I think it's really important that they go see a physician. I think the physician needs to be aware that, even younger people it can develop colorectal cancer. And so this is something that at least do maybe not a colonoscopy, but some other non-invasive test, just to make sure that they don't have colorectal cancer.
So recommended age of screening is 45, but that doesn't mean that a 30-year-old who might have some concerns shouldn't go in by himself.
Exactly. And then with that in mind, even though I mentioned previously that 75% of all colorectal cancers are sporadic, of that 25%, and there's dozens of different genetic and inflammatory bowel and polypoid type of diseases that are kind of all scrunched in together. But certainly if there is a family history, and the recommendation is really first generation, so mom, dad, sister, brother that had colorectal cancer, in particular if they had it at a younger age, the recommendation is to get a screen 10 years younger than the age of presentation. So say dad had colon cancer at the age of 40, all the kids should be getting screened at the age of 30. So that's also part of the recommendation and guidelines.
You say that this is one of the second most dangerous or second most deadly?
Deadly.
Deadly.
Correct.
But then on the other hand, you said it's one of the most preventable.
Exactly. And that's sort of the, I think for all of us in healthcare, and obviously then for the patients, that's the thing that makes it so troublesome. Because as I mentioned when we were talking before, I mean, you see an advanced colorectal cancer, and this is something that if someone at some point in time would have gotten their colonoscopy, or if they had a healthcare professional say, hey, you're 45 or you're 50 or regardless, you really need to have a colonoscopy. And that's one of the things that we've encountered is a tremendous amount of resistance. But regardless, we know that if they would have had the colonoscopy, there's a real good chance that we would have caught this when it was at the polyp stage, when it was at that growth stage, before it differentiated and formed the actual cancer, such that you do a colonoscopy. And that's the beauty of the colonoscopy. It's both diagnostic and therapeutic. In other words, you go in, you find the disease, and you can, like when it comes to things like polyps or say some questionable growth, you can biopsy it, or we have different techniques that we can remove the growth completely. And essentially by removing the polyp that is precancerous, you've essentially taken away the possibility of this person developing cancer in the future. And it also puts them on, puts that individual on our radar with regards to, hey, this is maybe someone that we need to bring in. Instead of bringing them in the usually recommended, 7 to 10 years, we bring them in and say, depending on the number of polyps and the degree of abnormality in the polyps, we bring them in and say 2 years or 3 years or 5 years. So that's what's key.
So you come in, you identify some polyps, remove them.
Correct.
That doesn't mean you're good. That means we're going to...
You're good for right now. You're good for right now, which is great. And, you know, with this in mind, it's like, look, this may be a one-time thing. Yes, there may be something about your personal genetics, not necessarily we're talking about inheritance, but your personal genetics. Definitely we know that lifestyle does play a role in it, and even though the recommendation came out that the age should be 45, the school was still out, if you will, with regards to etiology. Why are we seeing more and more colorectal cancer in this, you know, 20 to 49 age group? You talk to most folks in healthcare, I mean, the speculation's there, and if, you know, just, you know, we always say the first step in the scientific process is observation. I mean, look at the way we're eating and look at the way, if you will, younger people are eating. I mean, the, you know, lack of fiber, a lot more processed foods, these kind of things. And also, you know, older folks tend to be a bit more conscientious because of other health reasons, like, hey, you know, I got to watch my fats, I got to get more fruits and vegetables, I got to watch my red meat, etc. So with this in mind, you know, the thought is that, you know, more than likely we're dealing with dietary things. So hopefully when we screen someone, we remove the polyps, we make them aware, hey, there may be something going on with you. Number two, you kind of need to kind of rethink, you know, and at least in my practice, we really stress, you know, I mean, I'm sure my patients get tired of hearing diet and exercise, you know, and I hear every excuse, and as a native San Antonian that grew up on the West Side, I mean, trust me, I mean, I, grew up with, you know, all the good food, as everybody says, and every weekend my grandfather would go to the panaderia and come, you know, back with bags of, you know, panuls and stuff like this, but in spite of that, I mean, and that doesn't mean that you have to abandon that completely, but it really means that you need to emphasize the fruits, the vegetables, the whole grains, you know, the leaner meats, you know, stay away from the fried, greasy foods, stay away from this, you know, simple, you know, carbohydrates that have a, you know, high glycemic, you know, index. I mean, San Antonio has a lot. In fact, I was just watching this morning while I was waiting for surgery. You guys did a really good segment on diabetes, which was really well done. And I mean, that's, you know, that, you know, explained it, you know, well, but the take-home lesson is, hey, maybe I need to go for a walk, or maybe I need to watch what I'm eating, or maybe I need to, you know, change things up with regards to my lifestyle. And colonoscopies fit with that, I'm sorry.
No, you're fine. And you just touched on it a little bit, but how does colon cancer come about? I'm sure there's many ways.
Well, essentially, part of it is genetic. There are some abnormal genes that you have the potential to, if you will, turn on, and some abnormal genes that, you know, you have. And so, I mean, there are individuals where if you're destined and bound to have colon cancer, you may be destined and bound. Right now there's a lot, at least in even the GI literature, you know, talking about changing up your gut biome and, you know, with regards to fermented foods and things like this. And the feeling is that if you're eating like highly processed foods, if you're not getting enough fiber in your diet, that something in the foods that you're eating, by longer contact within the cells of the GI tract, kind of tip over that first domino, and with constant exposure, that causes the abnormal cell. And with it, your own genetics, you know, come into play with regards to, that's the thing that's kicking off the series of the formation of the abnormal cells that begin to grow and continue to grow.
Stuff. So why do you think there is such resistance to get screened?
I mean, a lot of it, I think, you know, I mean, a lot of it can be socioeconomic. I think, you know, it's diseases of the colon and rectum, you know, and I know, you know, folks here in the city, you know, did a lot with, you know, prostate cancer, with, you know, breast cancer, et cetera. Colorectal cancer remains very, for lack of a better term, unsexy. You know, it's odd how we tend to, you know, lower our voices when we talk about things like hemorrhoids, or we have to make it funny, you know, and unfortunately it's not a funny business. I mean, colorectal cancer is very, very, very serious. And I think for those reasons, there's folks don't like to think about their evacuation process necessarily, and definitely not the idea of having a scope placed through the rectum and examining the entire colon. That I'm sure folks may find distasteful. In the older days, the prep was pretty harsh. It was like a big gallon of salt water that you'd have to take, and that literally left a bad taste in people's mouths. And with that, there's a tremendous amount of resistance with regards to the prep, or people will still say the worst part of this prep. Fortunately, there's at least half a dozen of, excuse me, a half a dozen preps that are much more palatable and much more tolerable. And so we've kind of eliminated that. But I think a lot of it is just the whole idea of having in all frankness, a relatively long tube placed in through the rectum, and to examine the entire colon. But considering the alternative, and unfortunately I'm being on the front lines having to face the alternative and give people bad news and see them through their surgery, and surgery's painful, it's unpleasant, but definitely knowing that essentially 20-25 minute exam can be life-saving. I think that's just, who can argue with that? In all reality.
What does the prep look like now?
There's a variety. There's one of the preps that I like. They're 2 small bottles of medication that you pour into water, and you essentially mix it up, drink that down, and then followed by sipping on another glass of water, and then you repeat it in about 3 or 4 hours. There's a pill form prep. There's like 30 pills, so that's sometimes there's some folks that I'll ask, are you okay with swallowing pills, or are you okay with taking a fair amount of volume? And so if they prefer the pills, we certainly do that, and that's taken in with water as well. There's pretty much tasteless preps. The volume is significantly less. So being that they're tasteless, they're really not unpleasant. What we usually tell folks is to pace themselves. Unfortunately, because of insurance, sometimes they say the only thing that they can do is the big gallon prep, and they have. I usually tell folks to put a little bit of country time lemonade in it or something, and put it in the refrigerator just to make it more palatable, and just sip it, over a period of time. But definitely it's available, so it's much more, it's much, I wouldn't say pleasant, and I jokingly tell folks this is not going to become your favorite, after dinner drink, but it's much more pleasant than it used to be. And it's one of these things that you may have to go through every 6 years or 5 years or 7 years, depending on when we're bringing them back. But again, it beats the heck out of the alternative.
Is there anything people should be afraid of when they go in for a screening?
It is a procedure. It is a surgical procedure, and any procedure is going to have its associated, potential risk. There's certainly, certainly risk associated with perforation, unintended organ injury. You're dealing with a flexible, lighted tube that's going through the entire colon. And some people have a very stiff colons. Some people, because of previous surgeries, have a lot of adhesions. And if the endoscopist, in moving the scope through, can go ahead and cause a tear or a perforation, that's certainly a possibility. At times, even when we do the biopsies, depending, because some of the biopsies that we do is with an electrical current, because that way we remove the tissue and we essentially coagulate the underlying tissue. Some folks can have what we call post-polypectomy syndrome, where you have a small perforation. Sometimes this could be treated medically. Like a perforated diverticulitis with antibiotics and with bowel rest. Sometimes it requires surgery. So that would be the biggest concern. There's very exceedingly remote complications where people have had small splenic tears, which usually can be followed along and not operated on. But these are all possibilities. But again, all these complications that and potential risks that are associated. I mean, we're talking, and it depends on the experience of the endoscopist. Much less than 1%.
How frustrating is it seeing a case that's too far gone?
Well, I mean, it's sort of a, we can't, we can't bring back the past. And so, I mean, from just a humanistic standpoint, I mean, it's exceedingly frustrating because, but if we spent all our time saying what if, I mean, we would never move forward. And so at that point in time, the thought is, number one, let us move forward. What can we do to get this patient well again? That's it. That is like the sole focus. The other part of it is, okay, if you will, what lessons can be learned? Like if this has happened, say, in a younger individual, it's like, hey, make sure your brothers and sisters get screened. Make sure your kids, when they become of age, get screened. It's, call your neighbors, wake the kids kind of type thing with regards to putting the word out that the importance of colorectal, cancer screening. And that's trying to get some positivity. I mean, yes, the ultimate goal is to get them well, to get them better, to get them cancer-free. That is always 110% the goal. But if by the same token, if we can say, hey, we really need to get the word out because this really could have been prevented. I think that is definitely supersedes any personal frustration they may feel.
Being that this is Colorectal Cancer Awareness Month, and this is what this piece is about, what's your message to the viewers?
I mean, it's simple. Get screened. Be aware. I mean, first and foremost, this is something that's completely preventable. Number two, lifestyle change. Get some physical activity. Definitely some type of physical activity. Get out there and move. Definitely eat right. Get your fruits, vegetables, whole grains. You don't have. I tell folks, I mean, this is Texas. We're not going to be, but we're not telling folks to be vegetarians. But definitely increase the amount of fruits, vegetables, whole grains. The recommendation in women is between 25 and 30 grams of fiber daily, and men between 30 and 35 grams of fiber daily. And it's easy now because everything is labeled, and you can see the amount of fiber a particular food has. If not, everyone has a phone. How much fiber is in Brussels? In 3 ounces of Brussels sprouts. Boom, you have an answer. So it's just at that point in time, it's just a question of the math. But definitely get screened. Definitely start to change up the lifestyle.
Good stuff. I think that just about covers it. As far as statistics, have we seen anything significant or anything you can provide us with?
The biggest thing is the increased incidence of colorectal cancer in younger people. That's probably first and foremost. And it, like I said, and the best way to put it is you're at higher risk just by the numbers if you were born in 1990 than if you were born in 1950 with regards to the incidence. The incidence has risen significantly. And then the other thing, as I mentioned, because it's definitely worth mentioning, is the fact that let's not forget our elders. I mean, if you're 78 years old, live on your own, driving your own car, making your own decisions, walking, 5 miles a day, and when I'm, what comes to mind is one of my patients. No, let's get your colonoscopy done. I mean, it's my understanding that Medicare doesn't even pay for screening, and that's that's a shame. I mean, let's not write off our elders. I mean, they're sort of our treasures. I mean, this is where all our traditions stem from. These are the folks that we need to keep around and learn from and actually treasure. So I think that's key.
Good stuff. I think that just about covers it. Unless there's anything else you want to add, something I might have missed.
No, I think we're good. I mean, you tell me.
One question I do
Yeah.
have is if a young adult is getting ready to get ready for the screening and for prep and being ready for the procedure, what advice do you have for them?
Okay.
And you can just go look at him.
Okay, cool. With regards to prepping, usually the day before, you're on a clear liquid diet. We usually, and this is for the colonoscopy in particular, we usually say nothing red or nothing purple, because sometimes if you have a little bit of that red purple dye from whatever you drank is still in your gut, it may kind of throw the examiner off. But you're on a clear liquid diet. Usually, at least in our office, and there's different ways that the prep is administered. Usually in our office, we have folks start about 2 or 3 in the afternoon. Sometimes it's broken down into 2 sessions. I've had very good results just doing kind of 1 set prep, and usually it starts to work probably within 45 minutes to an hour of starting the prep. In other words, it's going to make you go to the bathroom to the point that you're just passing clearish, or if not, slightly yellow tinged fluid, which the yellow is the bile that your liver produces. And so usually by bedtime, you're essentially done with regards to the prep. Then nothing to eat or drink past midnight. And I personally tend to do the vast majority of my procedures early in the morning, because I don't like folks to be without, without eating. They've been on clear liquids, already for quite some time, so they're going to be pretty darn hungry. So I tend to do my scopes early in the morning. And then with the procedure, once it's done, the newer types of sedation, and they are, and I think I can't stress this enough, is that they are sedated for the procedure. They will not feel a thing. And with the newer anesthetic agents, they're very clean. The way that they're metabolized, you don't wake up feeling groggy. And in spite of that, though, we usually tell folks, take it easy that day. No driving, no heavy lifting, no strenuous activity, no major league decision making. And then the following day, they can return to all normal activity.
Good stuff.
Good. Was that